Okay, thanks for the invitation, and thanks on behalf of the Slovenian Dental Society for having me speak. I'm going to talk about my experience with implants over the last 25 years that I've been practicing, and I always like to revisit our history with this. And if we look at the European and American history of implants starting in 1809, when Napoleon was fighting the War of the Fourth Coalition against the United Kingdom, a French dentist named Magilio was making gold castings and inserting these into extraction sockets, doing some of the first recorded European implants. In 1895, there are a few breakthroughs that impact medicine as much as Röntgen's discovery of the X-rays at the University of Würzburg in 1895. And this is a photographic plate of his wife Bertha's hand that he took, and you can notice the wedding ring on there. Well, news traveled quickly of the X-ray to the United States, and just a few years later, in 1903, Dr. Charles Edmund Kells opened the first dental X-ray lab in New Orleans in the United States. And he was adjusting the exposure with his hand on the films. And unfortunately, he subsequently took his own life and had his cancerous arm amputated because of the radiation. That's Dr. Kells and his practice there. In the 1920s, in the United States, we had some famous gangsters like Al Capone and Prohibition, and Dr. William Coolidge developed an oil immersion tube for taking periapical radiographs in the 20s, and General Electric manufactured 6 of these dental units for the US. In the 30s, in San Francisco, we constructed our Golden Gate Bridge, which is famous, and Dr. Alvin Strock, an oral surgeon, was implanting Vitalium screws into the jaws of humans and dogs based on his observation of physicians performing hip surgery, orthopedic surgery. In 1931, Broadbent, an orthodontist, invented the cephalometer, which is on display in Cleveland, Ohio. And he showed this at the 1933 Chicago's World Fair, and he was looking at facial development using serial cephalograms. And in the 1940s, when Benito Mussolini declared war on France and Great Britain, an Italian dentist, Manlio Formigini, was also inserting implants that were cast into extraction sockets. After the conclusion of the United States war effort and on their return to the US, Aaron Gerskoff and Norman Goldberg developed the subperiosteal implant in 1948. And these rudimentary things kind of looked like an impression tray with 4 posts on it, an old alginate impression tray. And we'll return back to this because this is surfacing again. In Helsinki, Finland, in 1949, Professor Patero published on the principles of panoramic radiography using extraoral film. And you can see his drawings of the first panoramic film. So this is 1949, and that technology stayed pretty consistent for quite some time. In the 60s in New York City, if you're a music lover, you might get to see Bob Dylan or David Bowie. And there was a dentist there named Leonard Linkow who was doing some of the first endosteal blade implants. So these devices were placed in a linear osteotomy in either the upper or lower jaw. They were preformed, and you would select based on these sizes. In the 70s in Sweden, the band ABBA reached the top of the charts with the Dancing Queen. And in 1978, Dr. Brannemark presented a two-stage threaded titanium root form implant based on his research in the rabbit tibia. And this is where things really started getting exciting for dentistry. In Switzerland in the 80s, Dr. Straumann and Schroeder from the University of Bern formed the international team for implantology in 1988. And the late 80s, when I was in high school, we were busy inventing MTV in the US. And at this time, in the late 80s, Trophy introduced radiovisiography. So now we're getting into dental tomography and the axial tome and tomax imaging. So you can see that there. In the 90s, a French company, so this is, decades later after Patero in Finland, Signet introduced the digital panoramic radiograph. And you can see that there. Same time, I got my first cell phone and my first pager. This was great. This was not so great, depending on the hours when you're being called. Most of us are old enough in here to remember Y2K in the 2000s. We survived that. This is about the time that I graduated from the Oregon Health Sciences University, and I met Yanina, and we got married. And we moved to Tucson, Arizona, and I built a surgery center there. And I spent the first half of my practice privately and then sold the business to come teach. But when I was there, Newtome in Verona was a company that was introducing CBCT to the dental profession. And this was really revolutionary, particularly for implant placement. I decided to go to Virginia Commonwealth University with Yanina in 2013. And since then, I've been in charge of the dental implantology program in the oral surgery department. And with the advent of CBCT and CT, we started doing the guided surgery right away. And this is an article from the late 90s by Ozan, and he studied three types of guides. One was tooth-borne, and that was the most accurate. And then he did a bone and mucosa-borne one as well. And that really started us with the static guided implant surgery, which really started taking off. And it's using a CD-generated CAD/CAM stent with metal tubes that allows us to place implants very accurately. We call it static because you cannot change the position after the planning. So it stays the way you planned it. So you need a CBCT, and then you also need an optical scan like the Medit or the Trios that you have outside there. And then you plan in software the implant position, and we all are familiar with this. So we can do this fully guided where we have an osteotomy preparation and we also insert the implant through the tube, or we can do partially guided where we prepare the osteotomy, freehand place the implant, or we can just use a guide with a 2 millimeter drill, and we call that pilot drill guided. So let's just take a look at one of the ones that we did, the residents did for me. We're going to extract this primary canine here, which is a great tooth to be able to do an immediate on because it has a short root. So we can use the Trios scanner and do a virtual extraction of the case. I started printing my own guides myself using a small Formlabs printer. And right now we're registering the surface scan with the bone scan by picking 3 reference points. Once those two are merged, we can go ahead and outline the design of the guide, going a couple teeth in front and back, insert the appropriate tube. This is a BioHorizons implant that we're going to place. And then we can go ahead and do the surgery. We're going to simply extract this tooth It has a very short root, so we'll get good primary stability. And then we'll put our little guide on that we printed in the office. And we're going to go ahead and prep this. This is going to be fully guided, so the implant osteotomy and the implant are done through it. We put a abutment on it, and we scanned it with the little Plan Mecha scanner, and we went ahead and milled out a provisional prosthesis on the day, and that's how the patient leaves. They started with their primary tooth, and they leave with a nice provisionalized canine. So we went ahead and we looked at our guides, and we found out that the ones we were making ourselves were about as accurate as the ones that were commercially available at the time. And we published that in our literature in the US. And then we also found that, of course, the fully guided surgery where we put the implant through the guide is more accurate than the partially guided surgery where we don't, where we freehand place it. Now, mind you, those discrepancies are small. They probably are not clinically significant. All these are within a degree or two of the planning. But one of the advantages we found with the static guides is we can get accurate implants placed, but we also can deliver a nice fixed provisional prosthesis at the same time. So this was a VCU student riding a bike. He got hit by his car, common injury, and lost his 4 front teeth. And so we have a STL file, and we are going to format that with his cone beam CT. He had one area that was deficient in bone here, so we decided to cantilever that. And we planned the provisionals and the implant guide at the same time. And we were able to get in the box. This is what comes. This is your guide. Oh, excuse me. This is the guide here. And this is a nice milled provisional that's non-engaging with these titanium bases. So let's see how we did here. One of the nice things about this particular system is it's very accurate. So when you look at the implant being placed, you can see that we have a hex on the implant delivery drill, and that corresponds with the internal hex of the implant. So you can very accurately position this where you want it. Now, one of the things you'll see if you do this is it's never quite perfect, even with all the technology we have, because when we put this down and it engages the guide, it will bend it slightly. So then the next 2 implants will be a little bit less accurate, and you can see that here. These are down all the way. This is because the guide sprung back. Okay. So then you have 2 choices. We can either submerge these 2 more or back this out. So we submerged these more, and we delivered the same day, and he got a nice result. He's very happy with that. And you can see the tissues are nicely healed. And this is the permanent zirconia restoration afterwards. So even with all the technology we've got, it's not quite a perfect system, but that's his result, and that's a nice result for him. We published a little paper on that, getting the guides and the provisionals, and we also kind of experimented this with a full arch case. So this is a lady that has lost her upper dentition. She has lower teeth, so this is risky business. This does not always turn out great, and I would caution those of you that are wanting to do a high volume of this. It may not turn out fantastic when you look at it years down the road, but she has no alternatives. She came to me with no teeth. But what we're doing here is what's called a dual scan protocol. We scanned her denture in the CBCT and developed a surface scan with that. And then we overlaid it on top of her CT scan. And we can plan the implants in space. This is a manufactured guide, which is very nice. So it has the denture teeth on it so we can seat it correctly. And then this is a bone-borne guide because we are going to actually place 2 pins in here. And then we take this piece out and we're left with these tubes. You'll notice we can do this flapless, which is nice. And the depth and angulation are all taken care of. And the same day we put on the abutments, but it's not perfect again. Okay, so what I'm usually doing on a case like this years back is I'll just insert a cotton tip applicator through there and put a little bit of flowable composite on. And then at the final stage before you seat it, go ahead and use that flowable composite and make your small adjustments with the titanium bases. So don't glue these in until you seat it. Okay, and then you can take care of those small discrepancies in the implant position. And that worked well for her, and we did this probably 10 years ago, and it's held up nicely. So the question becomes, how many times can you do this flapless surgery? And Janina and I had made a lot of guides, and what we did was we went back and we looked at the planning. And she went ahead and measured how many millimeters of keratinized tissue are on the buccal or lingual aspect of the implant avatar when we decide we're doing that. And what we found was on the buccal and the maxilla, 77% of the time you have enough tissue to do flapless surgery. So that's a good percentage of the time. On the mandible, as all of us know, we don't have a lot of keratinized tissue often. So in the mandible, when we looked at that, it was only 22% of the time. And on the lingual, it was 25, and it's almost 0 in both areas. So oftentimes you have to do something to address that, and that is make a flap, or else you can't just drill through and have no keratinized tissue, or else you end up with the problems that Janina was alluding to earlier. Now, we can use stacked guides also, and we can do bone reduction. So a lot of these patients that are getting full arch treatment, we end up removing some bone. So one of the advantages of static guided surgery is being able to put a guide on, fix it with screws, and then shave the bone to the predetermined height. And then on top of that guide, you will put the implant guide. And then on top of that, you will stack the prosthesis. So you mount one metal guide, then you reduce the bone, you put on the next guide, place the implants, put on the next guide, and deliver the prosthesis, which you can see here. So that is still fixed to that metal guide. So this is the second one for placing the implants, and then we put the third guide on. And this is another risky case, fully edentulous maxilla against a natural dentition. That's a difficult situation. In this case, we're doing 5 large implants for that, but they sometimes don't hold up. The alternative way that we can address some of these things is with dynamic navigation, which uses a computer. So we put a jaw tag on the mandible or maxilla, and then we also put a tag on the handpiece. And one of the things I like doing about this is if you can't seat a guide, say for instance in this patient that has a fibula flap and there's a large skin paddle, obviously you can't put a static guide in it. Will move all over the place. We can use dynamic navigation. So let's take a look at some of that. And there's a couple systems available for this on the market now. So this is that fibula patient. This is the jaw tag, and this is you actually looking at the computer doing the surgery, and you can calibrate it so that you can tell how deep the implants are going in. And it's all done off a temporary implant that we place in the midline. So the computer system is telling you where your handpiece is in relation to the jaw. And then at the end, we take out that temporary implant. And it's very nice for doing flapless surgery on, say, a fibula where you have no frame of reference. So this gentleman did very well with that and has his 4 implants in place. It's also good in the back for those of you doing static guided surgery. Sometimes the patient can't open wide enough to get the drill and the guide in the back. And if you haven't had that happen to you, this is what happened to one of my residents. They worked all night. They made their guide. They're going to work on a classmate and do a second molar, and they're going to bring the drill in, and they notice, oh, that's not even close to fitting. With the dynamic guided surgery system, you can use any drill and calibrate it. So you don't have to use the extra long drills that the guided does. Another advantage of dynamic surgery is you can make flaps. So this is a posterior case. There's not enough attached tissue. So what we're going to do is make the incision, and then we're going to go ahead and place the implants using the guides. And we can make adjustments to it. It's not static. That's why it's called dynamic. So you can move the drill around, reposition the tissue, and we have nice keratinized tissue now on the implants. Now, one of my colleagues, Mike Block, studied this, and these are great articles if you're interested in getting into dynamic or static navigation. Particularly, this is a great review. Static or dynamic, choosing the method of guidance, and it will go through the pros and cons of both of them. But so you don't have to read that, I summarized this for you. So advantages of static are it's very accurate, a little bit more accurate than dynamic because it doesn't depend on your hand. You can do flapless, you can reduce the bone guided, and you can deliver those really nice provisional restorations I was talking about. And it's a lower initial cost. The dynamic machines are very expensive. You could spend $100,000 on one of those. With ordering the guides, it's less expensive. And the learning curve for static is less. You simply snap it in and drill, if it's tooth-borne. Static guided surgery is not a great choice if you have patients with limited mouth opening, like we looked at in the posterior. If you want to place an implant on the same day as your CBCT, unless you're making your own guides, there's going to be a delay of a couple of days. With dynamic, you're ready to go right there in the office. Second molar implants we talked about, tight interdental spaces where we can't put a tube, like a lateral incisor, particularly in the mandible maybe. And as we talked about, soft tissue manipulation and the fibula case. One of the recent advances now with at least the restorative is the photogrammetry. And I didn't see anyone down there with that technology today, but basically we're using non-contact images of an object to get a 3-dimensional representation and model of surface measurements. And this becomes really key when we're doing particularly the full arch case. So this is a case where we're going to do serial extractions. So we put in our guide and we're going to put in these first couple of implants, and then we'll switch to another guide, and we're placing the remainder of the implants by using the prior to stabilize the guide. And what you're going to see here is that the same system that we use for the dynamic guided surgery, we can use to position the implants in space. And that's what's happening here. So we're using this wand. The computer will register these implant scanning bodies, and now it's got the information 100%. So we placed these implants in the morning. Dr. Mendoza, one of our prosthodontists, using this information, printed on the same day this provisional, which is extremely accurate, 100%, more so than the ones I showed you using the static, because this is a real representation of where the implants are after they're placed. So very, very accurate stuff. The guided surgery is not always so simple. And sometimes when I'm teaching it, when we first started doing it, actually the failure rate went up. There are some things about it that will lead you to believe maybe your implants are more stable than they are because the drill will bind to the guide, the implant will bind to the guide. And this is another full arch case we did with one of my residents, and he put a tightening on and boom, the implant disappeared into the sinus. So it's not always foolproof. You have to use caution whenever you're doing this. So we did a little Caldwell luck and we retrieved the implant out, and then all on 6 turned to all on 5, and the patient did fine. I think now in the US, our standard of care for implants is to get a CBCT on almost all of the implants that we're doing. And oftentimes what we'll find out is that we just don't have enough bone. So early in our careers at the university, we got interested in doing some of these regenerative techniques. And the simplest one is this closed augmentation of the maxilla. And it can be done with or without a membrane. And let's just take a look at that. This is for horizontal bone addition. We're going to use a xenograft, BioOS, a Geishlich product here, and we're going to correct this defect here, this horizontal defect. So the tunneling is only good for the horizontal dimension. And in this one, we have enough bone to place the implant. We're going to do the augmentation after we place it. So this is one of my residents doing the planning. We went ahead and printed a surgical guide in the department, and you can see that here. And then we went ahead and we're going to go ahead and do this flapless because this is one of the 77% that has adequate keratinized tissue. So we're drilling the implant. And this is actually partially guided. So partially is freehand placement of the implant using the guide for the drill. And this is finished. And we got great torque. We decided to do a single stage surgery, so we'll place the healing abutment on at the same time. And then we'll address this little horizontal defect. So I like to cut a tuberculin 1 cc syringe so that it fits in the flap, and then go ahead and hydrate your graft nicely. And then you can just use this syringe and scoop it up out of a small dish. And once you have the ½ cc of bone is all you need for something like this. If you want to cover it with a membrane, you can, but you don't actually need to. Sometimes for residency education, we do things that we don't need to. Dr. Hall wanted to do the membrane here, so we did. So we're making a small incision in the mucosa, and we need to get below the periosteum. And then you want to go ahead and dissect down. If you're going to use the membrane, roll it up, and then just use a small forceps and put it in the wound. And you don't want to push it back all the way. It should stay over the graft. So we're going to place it in and leave a portion of it exposed. Okay. Now the graft will go under that membrane, and we're basically going to put that in using our syringe. So the bevel helps you get below the periosteum, and then you just push this in. Very simple. So we're pushing it in now. Be careful not to push the membrane back into the wound too far. And we can condense the bone a little bit, suction away the excess, and you can see our membrane is still there. So it's in the right spot. And we'll just simply close this with a couple dissolvable sutures. Very easy procedure. Patients tolerate this really well only good for horizontal augmentation. But you can see on the postoperative CBCT scan from that day that we have bone out on the buccal of the implant. So we've done a nice augmentation there. Now, about the same time, I was having difficulties using PTFE membranes. So we wanted to see if the PTFE was more effective than the tunnel. So Janina and I devised a little study. And this is what the PTFE membranes are. We refer to them as Gore-Tex membranes. And this is a lateral incisor site. This is, again, a horizontal augmentation to increase the width. So we're going to go ahead and make a small flap. And we're going to elevate that up. And you can immediately see the defect. So that's where our bone needs to go. We're doing a periosteal release. It's very important to cut the periosteum across so that you get no tension on the flap. And oftentimes when you're beginning, I suggest you use a piece of aloe foil, maybe from the suture pack, because the membranes are very expensive. And if you mess up trimming it correctly, you just lost $150. So practice with that. These membranes do come pre-shaped. So in the anterior area, they look like this. So we're securing it to the palate using a suture, and then we'll secure it on the buccal aspect using, we're drilling some cortical perforations there. We're going to use an allograft in this case, which is cadaveric bone. And once that's in place, then we'll fold the membrane over, and then we can use a couple of screws to secure it so it's not moving. And that's it. And then we close it up. And then 4 months later, we can go ahead and do our implant. Now, what we found when we looked at these tunnel versus the PTFE was that we had more complications with the second one I showed you. The body doesn't respond to it as well as the collagen membranes. So we got more infections and we got more dehiscence, and we didn't get to do as many implants in the patient. So that was, we found in our hands, not as good of a technique. Janina referred to this tenting screws technique earlier, and this is probably for small horizontal augmentations. I like this technique of the GBR techniques I'm showing you. It's kind of a hybrid between the two. So let's take a look at one. We can reliably get maybe 3 to 4 millimeters of augmentation using this. So here's a patient with an anterior defect, and you cannot really graft beyond the alveolus on either side. So that's all you're going to get. So what we're doing in this is we're leaving a couple screws high so that we can pack bone underneath them and they guard the graft against moving. The enemy of all these GBR techniques is the orbicularis musculature. When patients are talking over time, they're moving that graft around. So by using screws or membranes, we try to decrease that graft migration. So this patient has a melanotic zone of keratinized tissue. So we're going to do our vertical release in the posterior and just use one of them so we don't disrupt that and so that it's more cosmetic. And we call this an open book flap. So instead of 2 vertical releases, we're going to do just 1 posterior. And as we raise this up, you need to get all the soft tissue off the bone, clean this off really well. We're making a small pocket in the palate to put the membrane in. We're going to use a collagen membrane in this technique. So we're not using PTFE because we don't like the way it heals. So there's our defect. And right now I'm just putting with the pencil 2 dots where I want him to put the screws. The screws come in different lengths, and you can see you're going to leave the smooth part exposed. And that's about 3 millimeters or 4 when it's adjacent to that perio probe. So we'll put 2 in this case. It's almost all the way in. And again, we're going to graft underneath these, and these screws will help stabilize the graft. Now, we have to take those out later when we put in the implant, but that's very simple to do. And you actually don't even need a flap. You can just poke the tissue on top of them and take them out. So that periosteal release you just saw, we need tension-free closure in all of these. So we're putting our collagen membrane in. We're using allograft here, cadaveric allograft, freeze-dried irradiated bone. You could also use xenograft. You can use autogenous. All of them have fairly equal results. So once this is packed in place, remember we're going to cover it with the collagen membrane, and then we'll close this up. In this case, we're using some PTFE sutures. We'll remove them in 10 days, and then we're going to come back in 4 to 6 months to go ahead and put the implants in. So what did we find? This technique allows you to graft vertically and horizontally, and it has similar complications to the tunnel. So of the 3, the PTFE or Gore-Tex technique had the most complications for us. The other 2 techniques were pretty equivalent. The quickest and easiest is that tunnel where we inject with the syringe. But if you need a little bit more control, you can use these tent screws. I like doing mesh guided bone regeneration. It allows me to do things both vertically and horizontally. And let's look at augmentation here. So this patient has no ridge almost. This has been edentulous for a long time. There's no way we can get an implant in that right now. And we've all seen this. We call this a saddle deformity in the US, and it's really common in the posterior mandible. And we're going to use a titanium mesh to fix this, which I think is the best thing to do for 3-dimensional large defects. Now, in this case, we went ahead and we pre-printed a model of the defect so you can bend your mesh before the surgery, which will save you quite a bit of time. And the residents like doing this, and it allows them to be more successful when they do the operation. So we're going to bisect the keratinized tissue in this. And then we're doing the periosteal release. So we're cutting the periosteum. And we can do that on the lingual side as well. You need to be very careful of the lingual nerve there. We don't want a patient with a numb tongue. And now we've got our pre-bent mesh, and we'll secure it on the lingual side using 2 screws. And then we're going to pack the bone underneath the mesh and secure it on the buccal. We're going to use allograft in this case, and we're mixing in some platelet-rich plasma as well. That makes the bone nice and sticky, and you can see us packing it underneath the screen. Now we're also going to secure this on the buccal side of the mandible as well, using a couple of screws. And then this is going to sit for about 6 months while the bone heals. You can cover the top of the mesh with the membrane. Or you can just close it over the mesh. This case, we use the membrane. We'll put our sutures in, and that's the closure. And then 6 months later, we're going to start doing our implant planning. And we're putting our virtual teeth in. We're going to restore this in crossbite. The patient had a crossbite before. We can use a virtual articulator and figure out what our provisionals are going to look like. I don't like doing immediate provisionalization in the posterior mandible, so in this one, we're just going to put the implants in. But you can start to see now that we've built about 3 or 4 centimeters vertically and horizontally right here. So before the implant was in space, now we have a really nice GBR result in this case. This requires a flap the same design as the original because, of course, we have to take this large piece of titanium out. And when we re-enter, we'll do the same incision. The mesh is really tenacious, so when you're taking it off the bone, sometimes it sticks there really, really hard, and you have to pry it off. So we'll take out all the screws. And lift up the mesh. And we have to cut the mesh off because it's encapsulated with fibrous tissue. But you can see now we've got a nice wide ridge compared to this. We've grown a lot of bone. And it's dense bone. It's D1 bone. So we're going to go ahead and put our guide in. And we'll do our implants just like before. So these are fully guided implant preparation and then implants through the guide also. We get really nice torque. So if it's above 35 Newton centimeters, I'm going to go ahead and put the healing abutments on the same day. And then we close this up. One of the oldest techniques I've been doing is also one of my favorite. If I'm needing to graft an area here, I can just simply steal some bone from the posterior ramus. So this is a thin ridge. And what we'll do is we'll go back and graft the buccal aspect. I put an implant here just to show that you need 10 millimeters above the nerve. So if the patient doesn't have enough bone above the nerve, you can't do this technique. But autogenous block grafting has been around for a long time, and it's still a successful technique. Patients like it because it's their own bone instead of the cadaver, so some of them prefer this. It does have some donor site morbidity, and you can get a nerve injury if you don't know what you're doing. So we'll elevate a flap and then put a vertical and distal release in. And it's a similar incision that I use for taking out wisdom teeth. And we're doing the periosteal release at the beginning so that this will be tension free. And now we're just going to measure how much bone we want to take out. And when the residents are beginning, I usually draw this with a sterile pencil so that we know what they're going to do. Measure how thick the cutting is on your burr, and you're going to use that for a guide for how deep you should cut this so that we don't inadvertently cut into the inferior alveolar nerve. And then this is really quick. You can harvest these in a matter of minutes. I'll just make the 3 cuts, 2 verticals and 1 on the top, and then just break this off using an elevator. So you'll see once we connect the cuts, I'm just using an extraction elevator, break the piece off, and we're going to transport this anteriorly so that we can put that implant in. Sometimes you have to use a little bit of force, but just be patient. You'll get the block out. Now we're going to use a lag screw technique, which involves using 2 drills. There's a larger drill that will go through the graft and then a smaller drill. So we don't want to place tension on the graft. So fit this in place. Sometimes you have to drill a little bit from the marrow side. It needs to fit really flat. Okay, it needs to adapt really well. So you're going to do a little bit of carpentry, which is another reason I like it. I like doing these grafts in particular because I enjoy messing around with this stuff. So we're gonna use 2 screws, which is what I suggest. That way the graft doesn't rotate. And then you can see the 2 drill sizes. So the larger drill goes through the graft so that the screw should fit passively. And this is going to countersink a little bit with a round burr so that the screw head fits flat. We don't want it to stick up above because it might dehisce through the tissue. After this, we'll just go ahead and screw this in place. And it's interesting when you go back to look at these after 4 months, sometimes they look the same. It looks like it just has been stuck on. In order to reduce its blockiness, sometimes we'll harvest some autogenous bone using a scraper from the mandible, and we'll put it around the edges in the hopes of it making a smooth contour. So that's just some autogenous cortical bone shavings. These scrapers are nice. If you haven't used them, I recommend them. You can use them for all the grafting procedures that I've shown you. It, of course, requires a donor site incision, but we'll put that around the periphery of the graft to try to make it smooth. And then we'll close this up. And I like covering these with a membrane that's resorbable. And we just put that over and close. And again, we have to take the screws out when we come back to put the implants in. And you'll see the graft there on the post-op. So now we have enough room. We've made 3 millimeters more width. And when we open this up, it's nicely healed, and these screws will come out. And you'll see that we have plenty of room to put our implant in. The last thing I'm going to end with is, remember when we talked about Dr. Gershoff coming back after World War II and inventing the subperiosteal implant? Well, I've been doing this long enough to where I've done a lot of full arch treatments, and unfortunately, some of them have catastrophic failures. I'm not a huge fan of zygomatic implants, so I never really got into putting those in too much because I didn't find them that functional, and the cantilevers were very large. I helped get in on the early development of this new KLS IPS implant that we're going to talk about. So this is the new subperiosteal implant, and this is custom 3D printed from the patient's cone beam CT. And we're going to anchor this to the zygomatic bone and to the piriform bone. And in the patient that is fully edentulous, you can see this is the last implant of their full arch treatment. 5 of the 6 have failed, and we're going to go ahead and take that implant out right now. And this patient has no bone anywhere. So instead of doing gigantic grafting, we're going to do this. Now, we've been doing these at Virginia Commonwealth for a couple of years. We probably have the most experience with it. The kit will come with the implant, and then it will come with corresponding guides. First, we're going to place these guides in, and they fit underneath the nose, and then they go on the zygoma, and we'll drill the screws first using these guides. So that's what we're doing there. There's the guide on. We'll drill the 4 holes on that side. And then we'll do the same thing on the left. And everything is done on a virtual plan. So you'll get a prosthesis along with this implant. So there's the implant. It's large. So it requires general anesthesia in the operating room. Although soon I bet we'll probably be able to do them in the office. And it has 4 Nobel abutments. And then basically we're going to cement a prosthesis that's very similar to the full arch prostheses you're used to. So that's the implant fully in place. We're going to place some alloderm on top of this to help thicken the tissue. So this is cadaveric dermis. And in the patient with a very thin periodontal biotype, you might think about doing this. And those are the 4 implant piers exposed. This is what comes with the implant. Very simple. Screw it right in. Patient leaves the operating room that day with their full arch prosthesis in place. So when I'm teaching this, I kind of talk about the first dentition is the dentition that we're born with. Your second dentition is the one where you get root canals and crowns. Your third dentition might be the full arch of implants, the all on X. And if that fails, this is going to be your fourth dentition, which will be this custom subperiosteal implant. I thank everyone for your time. You guys must be the good practitioners staying till this late hour. I appreciate your attention. Come introduce yourselves at the party.